Recording in progress. Assalamu alaikum, the short clinical station day. First scenario, we start as a neuro case. So the case, Dr. Rasha, what the case is? The name of the patient and the age, and we start the
Send
timing.
picture.
No, not the picture, the
Yes,
patient name.
Mr. Ahmed. Mr. Ahmed.
Okay.
Yes,
Start-
Mr. Ahmed. Mr.
Yes.
Ahmed.
How old is he?
Uh, 45.
Okay. Dr. Rasha, you can start now.
Mr. Ahmed, 45.
Yes.
Examine what?
Look into the patient and proceed.
Okay. Where is the picture? Hello?
Yes, here you go.
Hello?
Hello?
Yeah, I'm Dr. Auda Karim. I'm candidate for exam today. May I confirm that you are Mr. Ahmed, 45 years old?
Yes, I am.
Mr. Ahmed, I would like to examine you. Is that okay with you?
Yes, doctor.
Okay, so during our examination, if you feel any pain or discomfort, please let me know, okay?
Yes, doctor.
So I'm going to wash my hands. Okay. Okay, so I'm going to wash my hands. I will look for surrounding, if there is any walking aid, any wheelchair.
No.
Okay.
No.
Okay, so I'm going, yes, I'm going to start examinations by examining the hand of the patient, starting. I will examine
Yes, there's the
upper limb.
hand. There is weakness.
Okay. Upper limb neurological
Upper limb.
examination.
There's
Yes. Distal weakness or what?
Yes, there's weakness. There's distal weakness.
Okay, so I am going to do percussion myotonia.
Positive.
Okay. I'm going to do myotonic grip. Please, Mr. Ahmed, make a fist my fingers, please.
Myotonic what?
I will take grip.
How to do it? How to do it?
I will test. Yeah, I ask Mr. Ahmed to fix my my hands or my fingers, one fingers, and to make a fist. Okay,
There's
there is
delay.
any slow delay. Okay. So I'm going to check. Yes. Okay. So regarding the upper limb neurological examination, just there is a weakness, distal weakness. Apart from that, there is no sensation, no coordinations intact.
Yes, sensation is normal. Coordination is normal.
Okay. So I'm going to examine. Yes, I would like to check for the fatigability test in the shoulder.
How to do it?
Proximal myopathy. Okay, I will
How
ask
to do it?
Mr. Ahmed. Please do abduction. Yes, I will ask Mr. Ahmed. Please do adductions of your shoulder. Yes, several times, and after that, I will check for the power or proximal weakness. If it is become more weak.
Negative.
Okay, so I'm going to examine the eye of the patients. Look that there is a bilateral dropping of the upper lid of the eye of his eye. Okay. So just I would like to check the visual acuity. Please, Mr. Ahmed, could you help me by reading your upper eyelid up? So I'm going to check for visual
Yes,
acuity.
this normal visual acuity. Normal.
Okay, so H-shape movement. Please, Mr. Ahmed, yeah, follow me with your eyes only and fix your head. I'm going to move my my fingers. If you are see any, if you are see double or you are feel pain, let me know. I will do H-shape movement for this
There's double
patient.
vision.
Okay.
There's
Double
double
vision.
vision.
Okay, so I'm going to check the visual field for this patient.
No need.
Okay, I will offer fundoscopy.
For what?
Yes, if there's any optic atrophy or
There's no optic atrophy.
okay, so yes, I'm going to do fatigability test in the eye. Please, Mr. Ahmed, could I will raise my fingers up and I will ask Mr. Ahmed to count the number from the 20 or 10 20 down to 1, and I will yes, I will observe the note the speech if there is any change and if there is any dropping.
They're negative.
Okay, so I will yes change. I will observe for the face of Mr. Ahmed if there is any frontal balding and wasting.
1 minute
How
left.
to examine? How to examine?
Just I will check. I will observe the face of Mr. Ahmed, and also I would like to examine the facial nerve and also the facial nerve and the fifth cranial nerve.
Facial and fifth.
Facial, yes, yes. Okay. So also I would like to examine the cardiovascular
Okay.
examination for this patient.
There's a scar
The scar.
above,
Okay.
down the clavicle. Yes.
Okay. There is device.
Yes, there's pacemaker.
Regarding the pulse, the rate and the risk.
Pulse, there's bradycardia.
Okay. So any added sound, any murmur?
No.
Okay, so I'm going to check the lower limb neurologically, power, plant reflex, and also I would like to check the gait of the patients and yes.
Okay, time is up, Dr. Sarah. What do you expect the gate would be?
Yes, the gait of this patient could be high stable gait because distal
Are you sure?
weakness.
Is it
Yes.
high stitch?
There's in the gate. There's foot drop.
What?
Lower limb.
There's a foot
Foot
drop.
drop.
Okay, foot drop bilateral or when bilateral foot drop.
Unilateral.
Okay, unilateral foot drop. Okay, so I'm going to check the sensation.
Okay, time is up, Dr. Sarah. Let's start the
Time up.
examination. Yes, you can start now, Dr. Asha. Examine.
Okay.
Yes, presenting your case.
Yes, I have examined Mr. Ahmed, 45 years old, who, yes, on examinations, he has got, by inspection, he has got bilateral ptosis of his eye and frontal baldness and wasting also of temporalis. Apart from that, he has got sign going with myotonia dystrophia in the form of yes, positive myotonia, percussion myotonia, myotonic grip, and also he has got distal weakness and examination of the upper limb, and also on the lower limb neurological examination, he has got right foot drop. Okay. Yes, and on when with an examination of his cardiovascular, I got a scar below the left clavicular bone. Most likely, it could be a cardiac device. Okay. And the pulse rate is bradycardic. I didn't. Yeah. So regarding yes, no sign going with myasthenia gravis, negative fatigability test as the level of the shoulder and also in the eye, no change in the speech pattern, the cranial nerve intact. Okay, coordination intact. Yeah, I would like to complete my examinations by doing yes, by checking the blood sugar for this patient. Mhm.
And
Yes. Um, other um,
okay,
I
how to
didn't remember.
investigate?
Yeah. Yes. Um, investigations. Yes, it is clinically diagnosed. Just apart from basic investigations, I will do a genetic test for investigations, and also I will do and yes, EMG and nerve conduction, just to exclude the okay. I will do also investigations, genetic test and EMG, and also I will do investigation to look for complications like ECG, echo for these patients, and also I would like to examine yes, other. I will do other to look for other causes of like I will exclude myasthenia gravis. Like I will do anti-acetylcholinesterase receptor antibody and anti muscle specific kinase antibody. Okay. Mm.
Okay. What are the type of
And also, I would like
myton
to do respiratory function test or force vital capacity for these patients.
for what?
If there is any, yeah, just to assess the respiration or respiratory muscles. I mean,
Okay. How to treat?
yes, the treatment, non-pharmacological education and counseling about his conditions, MDT group, in the form of neurologist, physiotherapist, occupational therapist, and language therapist, and also psychology. Okay, psychologist. Um, yes, other I will do for these patients physiotherapy, also as I mentioned, and I will just his management, like supportive management.
Mm-hmm.
Um, yes, supportive. Um, also cardiologist also to for cardiac monitoring, and
Mm-hmm.
endocrinologist for diabetes and other complications.
Okay. What advice you want to give to the patient?
Um, advice for this patient. Yes, regarding the advice, because he has now a cardiac device, also medical art, bracelet, and also um, yes, okay, advice.
Mm-hmm.
Yes. Mm. Oh yeah, regular check with cardiac clinic and endocrine clinic also.
For what?
Yeah, to monitor his cardiac conditions and other associated conditions like diabetes. Yes.
Mm-hmm. Okay. Regarding this patient, how many type of myotonic dystrophy you know?
Actually, I think like three or more than three types, but I think
Mm-hmm.
the most common is the type 1 and type 2.
Mm-hmm. What are the genetic inherited for this disease?
Yes, autosomal dominant inheritance
Mm-hmm.
and
Mm-hmm.
with trinucleotide repeat disorder or
Mm-hmm.
anticipations.
Okay. What are the name of the gene?
CTG, I think.
Okay. Okay.
Mm,
What are this patient presented with distal weakness? Yes.
yes.
What are other differential diagnosis of distal weakness?
Yes, a differential diagnosis of distal weakness. Um, yes, differential diagnosis of distal weakness. Other like sensorimotor neuropathy, like chronic inflammatory demyelinating polyneuropathy. Yes. Okay. Distal weakness. Actually طارت لي من راسي. I forget it. Yes. Distal weakness.
Okay. That's
Okay.
enough, Dr. Rasha. You can comment now.
That's only last questions. What about expectation about the sensory regarding this patient?
Sensation, I think, intact. Yes. Regarding distal weakness اللي هي Charcot Marie-Tooth also. Okay, I think.
But
And other
against
causes.
that,
No deformities going with Charcot Marie-Tooth, like coloring of the tooth and اسمه شنو تاني هي بقول عليها. Okay. Okay. No deformities, I mean, of the foot. Okay.
okay.
Peripheral neuropathy can I put also, I think, can cause.
Yes.
I didn't remember actually.
No
Other
problem.
myopathy
Okay.
also. May I put other myopathy? But again, is that other myopathy could be proximal more
Like
than this.
weakness and wasting with the sensory normal.
Yes. Like inclusion body myositis and I didn't remember. Actually, I'm sorry.
Okay. Time up.
Yes.
Yeah, since 3 minutes. Okay, let's start the comment. Dr. Rasha, please.
Yes, overall is good, but I think you need to start it because I sent picture. I don't know that you see the picture or not. You need to start it from the picture and after that go to the hand examination. Because yes, I sent the picture bilateral ptosis. You need started to inspection bilateral ptosis. After that, examine the visual field and edge shape. I think the fundoscopy not need this patient. And after that, go to the limb examination, motor examination. Because this the patient bilateral ptosis. You have two differential diagnoses in the basis bilateral ptosis, myotonic dystrophica or myasthenia gravis. You need looking for myotonic dystrophica and myasthenia gravis. Started from the hand distal wasting. You need to do myotonic percussion myotonia and my hand grip. And after that, yes, you done fatigability test. And also you need ask the patient to close and open the hand to see if there's any delay. The fatigability test is done. And then after to examine the patient was wasting. You need to check the wasting by ask the patient to palpate the temporalis muscle, ask the patient to clench the teeth. Okay.
Yes, this is
And
with
then,
the cranium,
yes,
fifth cranium
is
nerve. Yes.
important regarding this patient, because this patient myotonic dystrophic wasting of the muscle of the face. You need to sure by ask the patient to clench the teeth and palpate the temporalis muscle. Regarding this patient, regarding the 7th and 5th cranial nerve, not need, because the patient is muscle disease.
Even the temporalis muscle at the part of the motor part of the fifth cranial nerve. That's why I will over fifth cranial nerve.
Oh, okay. And after that, regarding the fundoscopy, I think the patient because have the red reflex not needed to fundoscopy because not seen anything because patient have the red reflex is positive. Okay, and also because this the patient you have two differential diagnoses, myotonic dystrophic and myasthenia gravis. You need to do other sign of myasthenia gravis, like ask the patient to myasthenia snare, and also you need you need see if there's any scar into the neck. There's two scar, maybe scar for myasthenia, thymoma, or scar for or scar for a device like pacemaker. You need to offer to examine the gynecomastia and examine the test for testicular atrophy. And yes, regarding this patient, yes, because the patient bilateral ptosis, you need both two differential diagnoses, looking for myotonic dystrophica or myasthenia gravis. You need to do all the sign on examination, myotonic dystrophica and myasthenia gravis, to confirm and exclude. Okay, you understand me?
Yes.
Okay. After complete my examination, you need to check your blood pressure. I needed to check blood sugar and the gait, and also offer to do a testicular examination. And you need also to examine, ask the patient to check the sternomastoid muscle, because patient maybe have weakness into the sternomastoid muscle. This is important difference between myotonic dystrophica and myasthenia gravis. And offer to urine for glucose. Yes. The other differential diagnosis of distal muscle weakness with the patient weakness distally and sensation normal, motor neuron disease.
Okay, motor neuron disease.
Motor neuron disease is common, yes, motor neuron disease, because the Charcot-Marie tooth, their sensory, their hereditary sensory motor, the sensory is positive against that. But motor neuron disease, because distal muscle weakness, bilateral and sensory normal. One of the differential diagnoses, distal muscle weakness. Okay. Regarding the investigation, you forget CBK, you forget muscle biopsy, you forget blood glucose and thyroid function test, and you forget MRI brain.
Thyroid function test, why?
Yes, thyroid function test, because the patient, there's association hypothyroidism with myotonic dystrophica, and also regarding myasthenia gravis, there's hypothyroidism as the part of autoimmune disease.
Okay.
And needed to also the testosterone, echo chest X-ray. There's no treatment regarding education of the patient, because the patient disease is autosomal dominant disease, and also the patient try anticipation disease. There's maybe affected to the family with the early age, and also needed to the patient education regarding the general anesthesia, because the general anesthesia regarding some like this patient is serious. There's no treatment, just only a supportive treatment, because this patient, I think, done the pacemaker, no need into the regular follow-up by the cardiology.
Okay.
Okay. Overall is done, but it'll take message when see the patient ptosis, put into the your mind to differential diagnosis in the basis. Myasthenia gravis, myotonic dystrophica. You needed to an examination to rule out of these. Maybe myasthenia gravis, maybe myotonic dystrophica.
Okay.
Yes, thank you, Dr. Asha.
Thank you.
Okay.
Yeah, thank you. Very nice case. And as a neuro,
Welcome.
expected to have this such kind of cases. As a cranial nerve examination, you can see, or you can have proximal myopathy as in this patient. But BRD, it's not only upper and lower limb examination. Sometimes they will surprise you, examine the patient accordingly. So you'll see the patient as Dr. Rasha presented, the case of ptosis, and you will examine according to the finding, which is very vague. And it would be difficult to guess what's ongoing with the patient, right? So the best way is to observe. At the end of the bed, of course, you didn't examine Dr. Sarah. What are the surrounding? Very important. Such
No,
patient
I
you
examined.
mentioned. Okay.
Yeah.
Was there any?
Ask about surrounding, yes.
Okay. Was there anything about like wheelchair or
No.
No.
stick?
You
Nothing.
mentioned.
But it could be there. So it's better and it's important to ask and to observe. Okay, back to the initial finding, which is ptosis. As Dr. Sarah did, I think she started with the upper limb, but I believe you should start from the face and the haggard face, which is a very important features of myotonia. I think this is a temporalis muscle wasting, but in another way, we called it a haggard face or frontal busting. Sorry, frontal baldness. You have to also notify it to the examiner. This is by inspection. In the hand, you can say inspected for wasting or for fasciculation as lower motor neuron lesion or as myopathy. However, it wasn't there. I think the other feature, Dr. Sarah picked up them, started from the myasthenia finding. She ruled out by fatigability either the proximal or shoulder, even the eye. She did the fatigability test for the eye examination, as well as the counting, which is also important. So the features of myotonia dystrophica is very important to hand grip the patient, to test the hand grip of the patient, and to do the percussion myotonia. It's very important to notify them to the examiner, right? It's characteristic. You have to do it. This is for the distal weakness. For the proximal weakness, you will do the shoulder if you have time, of course, because if you want to do the power, all the limb power, you have to do the flexion, the fingers, the extension, the thumb, and the adduction and abduction. But I believe not in this case. You want to do the specific test. So the fatigability test, along with the hand grip and myotonic percussion or percussion myotonia. Then the face, you will do the count and single breath test you can also do just to see the nasal tone or reduce tone while counting, and the also the dropping eyelid whenever he look up. I think this is the finding of the patient, and the investigation already mentioned. The complication is very important. Cataract. It's important to offer the torch examination. You can see the cataract. Along with the fundoscopy here, you might have optic atrophy, right? It's one of the findings. And the diabetic change, if you have diabetes, long-term diabetes, you might have retinopathy, right? Apart from this, the cardiac manifestation already mentioned by the pacemaker or bradycardia, if you have time to examine, but I think no one will have the think even to count the pulse. But anyway, at least you observe the scar for the pacemaker. Okay, the scars also for thymectomy, but I think this is a case of myotonia dystrophica, so it's not myasthenia gravis patient. But put it in your mind, you might have myasthenic patient, not myotonic patient. Okay, muscle biopsy is very important. By the way, the gait here, I think the gait should be as waddling gait as proximal myopathy or as
Waddling
my
gait is proximal
yes.
myopathy, Dr. Basim. This
Yes.
patient distal weakness, stepping gait. High step.
Okay, so according to the type, yes, you're right.
Yeah.
And this type, it was distal. But as a differential of myopathy, it might be as waddling gait, but this is not the case, as you said. Okay, so it could be as high steppage gait due to distal weakness bilateral. Also, it could be also peripheral neuropathy due to long-term diabetes. Again, it will be a high steppage gait, right?
Yes.
Yeah, okay. Any question, Dr. Rasha or Dr. Sarah?
Yes, I want to ask Dr. Rasha regarding the advice. I didn't remember it. Yeah.
Yes,
What's your
regarding the
advice?
advice. Yes, regarding the advice, the patient education the patient about the disease has the patient is autosomal dominant, and also advise the patient regarding general anesthesia. I
Because of
think
his
this patient,
protein?
yes, some drug of general anesthesia not given to the patient.
في الجروب والله مصورين العلبة دي، بوريك صورتها في
Yes, anti-anesthesia medication
كريم
not
ديل
given
وكريم
not
نهار.
given to the patient because worsening his condition. Yes.
I think this is very advanced advice. No one can remember it. However, don't say genetic screening or family screening.
Not genetic screening, not genetic
Yeah.
screening.
Yeah, exactly.
But this, yeah, okay.
Yeah, so don't encourage for it. If you want to do, if he's planning for having children, so but I don't think in his age, you can advise if he has plan of having children. Otherwise, no need to ask or to do genetic screening. You want to do, you can do genetic testing to confirm the diagnosis, not to screen for the family. Okay.
Okay.
Any other question?
Yes, but I think this patient regarding the fundoscopy, because the patient have cataract, the fundoscopy is not offer.
Yes, I said by torch. You can see or notice the
Yes,
cataract
yes,
by your
by
torch.
torch. Yes,
Yeah.
yes, by torch. Yes.
Anyone
like-
want to comment? Yes. Yes, Dr. Sarah, what you want to say?
Yes, just I mentioned light reflex. Yes.
Yeah, yes, by the torch only. Okay. Anyone with question? Anyone want to add something missed?
Hormonal replacement also can be
Hormonal replacement? Sorry?
testosterone
okay, for
Yes,
testicular
and I
atrophy.
think
Yes.
this patient not needed to examine the seven cranial nerve.
Yes, I don't think so also. So what you want to do is offering testicular atrophy examination. Just offer, don't do it. Just to show the examiner that
Yes,
you know there is
testosterone.
complication. Yeah. Okay. Any other screening or information to be
may
added?
improve the dystonia also.
Sorry?
Phenytoin may improve the dystonia.
Phenytoin will work.
Yeah.
Yeah. You mean it works the condition
Proof anti-myotonic.
or
As
it will improve?
anti-myotonic condition. Supportive, yes.
Okay, but it's not. I think it's just prophylactic, right? It's not indicated, or I'm not sure about the indication. If Dr. Rabia with us, she can tell us as neurology
I
point of
think
view.
phenytoin
Yes.
for myotonia hand grab myotonia, given phenytoin for this.
Relax, yes. Just
Yes.
Okay, Dr. Rabia will give us
Yes,
a
yes,
hint also.
yes, they are right. Phenytoin and mexiletine for myotonia.
Yes.
Yeah.
Yeah, that's it. If myotonia is present, you have to give it. If not, don't give it prophylactically. No role
If there, yeah,
prophylaxis. Okay?
yeah. If confirmed, you mean?
Yes, yes, yes. Yani, you can do it in your examination. You will confirm myotonia by your examination. So you will give the medications once you
Okay.
confirm by your examination.
But it didn't cure the disease. Only to.
No. It's just yani for if seizures, you give the medication to control it. So
Yeah.
just to control the myotonia. There's no treatment of myotonic dystrophy.
Exactly. Yes. Okay. Okay. Thank you, Dr. Rabia. Anyone want to comment apart
Yes, and
from this?
also regarding this patient, not needed to examine the facial nerve because can be taken the time and there is no
Yes,
indication.
exactly. If you want to do, you can do the gait instead. You can do the sensation instead
Yes.
as well. Yeah, because you might have diabetic nephropathy. Sorry, neuropathy. So you might examine it by the sensation examination as a complication. Plus the pacemaker, of course, that the pulse. But I don't think cranial nerve here will be involved or should be examined, right?
Yes.
Okay. Any other comments? Okay, I will read the comments quickly before moving to the next scenario. Inclusion body myositis, Dr. Henry. Yes, I believe it's one of the differential, but this is also proximal, not distal. Right?
Yes. Can I answer this question? This questions? Yes. Occlusion body myositis can be one of the differential diagnoses because distal hand weakness. But there's no any other not affected in the face, and there's not caused any bilateral ptosis. Just only distal hand weakness.
I think it also caused some weakness
Yes,
as
proximal
proximally. Yeah,
in the
exactly. In the thigh.
proximal in
Yes.
the thigh, and distal in the hand.
Okay. Okay. Yeah, I think all causes of peripheral neuropathy, you can put it as a differential of distal weakness. All patient with peripheral neuropathy, they will have distal weakness.
Yes.
Yeah, exactly. Charcot-Marie tooth, yes, there is two types, so either the sensory or motor. But yes, you can say as a differential, diabetic polyneuropathy, yes. Guillain-Barré, of course, one of the differential. Myasthenia gravis as well. Motor neuron disease as also no sensation affection or spared sensation affection. Request assessment of swallow. Yes, thank you, Dr. Mariam. She mentioned SOL team. Very important to mention and remember this team in your assessment. SOL team, swallowing and language therapist. Please remember them in the Parkinson, in the myotonia, in the myasthenia, in the stroke. In any patient will have bulbar symptoms. Okay.
Yes. Mention.
Yeah, you mentioned it. Okay. Let's move to the next scenario. If no one more comment, anyone want to comment before moving? Okay, Dr. Rasha, ready? You will examine Mr. What the patient name, Dr. Sarah?
Yeah, I posted it in your WhatsApp. Okay.
Okay, wait. Yes, you sent me. Okay, wait. Yeah, Mrs. Julia. I will send the
Yes.
scenario now. Dr. Rasha Bediti, you will examine as well neurologically. Mrs. Julia, 30 years old, presenting with vision problem. Please examine her eyes and proceed as appropriate. Here you go.
Okay, the first of all, wash my hand and read an instruction. And after, go to the patient. My name is Dr. Rasha. I'm here to examine you. If you feel any pain, please let me know. I started into the eye by the inspection to the eye if there's any ptosis.
Doctor, I didn't give you permission to examine me.
Okay.
Okay, yes, you can do it now. Yeah.
Why?
Yes.
I ask by impression, yes, ask by I'm Dr. Rasha. I am here to examine you. Can I examine you if, yes, can I examine you?
Yes, you can. Yeah.
Okay. The first of all, I want to the general surrounding of the patient, and after that, I want to examine to see to the see the face of the patient if there is any ptosis.
Negative.
And after that, I want to start the visual acuity.
How you can do it?
Yes, ask the patient to close into the one eye and ask the patient to count to the finger about yes, close by one eye, close the patient one eye and ask the patient to count to the finger.
Okay, doctor, no need. Negative.
Yes, and after that, do H shape. Ask the patient to look into my finger and move it as the H letter.
Okay, give her instruction.
If you feel any pain or double vision, let me know.
Okay. Negative. Negative.
Yes, and after that, I use the light see the pupil if there's any small pupil, if there's any dilated pupil, and do direct and indirect reflex, light reflex.
Okay, negative.
And also, I want to do rapid, rapid reflex if there's any dilated in the pupil.
No, negative.
And after that, I do accumulation reflex.
Okay, negative. Normal.
Okay, and after that, do visual field.
Okay, how you can do it? Give your patient instruction.
Yes. Yes, ask the patient to close the eye into the same eye, and ask the patient to look into my nose, and move it my finger from out to the end, like X letter.
Okay, so
I by I.
okay, so
There's
you post
there's any
the
positive
picture now.
finding?
Dr. Batim, you can send the picture now for the visual field, please.
Yes, you can see it in the chat box.
The visual field, Doctor.
Okay. After that, I do fundoscopy.
Okay,
Yes,
how
you
you
mean
can
the
do it?
visual field the patient to the problem to the peripheral? Yes,
Okay,
you mean the visual field the patient to the problem to the peripheral and more clear in the central, yes?
as you see now in the pictures, just send it.
Yes. And after that, I do fundoscopy.
Give your patients the instruction of endoscopy, or how can you do it?
Yes. Yes. Dim the light and ask the patient to look into my nose, and tell to the patient I want to do using this instrument to see to the back into your eye.
Okay.
Okay. After that, I will go to the peripheral to check the pulse. Hello, check into the pulse.
Yes.
And there's a check if there's any check the pulse and check
For
in the
what?
hand if there's any extra finger polydactyly.
Okay, negative. The pulse normal.
Check the pulse if there's any bradycardia, if there's any extra finger. And after that, I will examine behind the ear if there is any airpiece.
Okay, negative.
And after that, examine to the heart if there's any basal crepitation, if there's any abnormal heart
1 minute left.
No, negative.
Hello?
Yes, negative. Yes, you are hearing me? Hello?
Yes, we can hear you, Dr. Sam.
Okay.
Dr. Rasha?
Hello?
Give her another minute. Yeah, yes.
Hello?
Yes, Doctora, continue.
Yes. After that, examine to the heart if there's any basal crepitation.
Okay, negative.
And after that, examine the patient, the gait and romping test. If there's any, if there's any problem to the sensation, and ask the patient the gait if there's any ataxia.
Okay, negative. Anything else?
Hello?
You want to examine? Yes.
After check if
Anything else?
if there's any skin rash.
Okay, negative.
And then do the lower limb if there's any weakness, any Babinski sign. If there's any problem in the joint position and vibration sense. Joint position, the lower limb joint position, any vibration sense.
Okay. Okay, so your time now finished. Present your case,
Hello?
please. Yes. Present your case.
Yes, okay. Regarding my patient, regarding my patient presented with blurred vision after examination, the patient there is the visual field defect, the most probably into the regarding this patient, this is Julia, presented with a problem to the vision on examination. There's the visual field defect into the the visual field defect is most probably the peripheral visual field defect, and also there's fundoscopy. Yes, okay, there's fundoscopy. There's a specule, bone specule. Regarding to the general examination, there is normal. Most probably have retinitis pigmentosa, isolated retinitis pigmentosa. I want to do I want to do basic investigation and genetic test to confirm
Patients, this
diagnosis.
retinitis pigmentosa.
Yes,
Okay.
this is retinitis
So-
pigmentosa, isolated retinitis pigmentosa.
Is there
If there's
okay, retinitis pigmentosa? Can you mention for me it syndrome?
the second differential diagnosis may be
No.
yes, there's isolation retinitis pigmentosa.
Yeah, any syndrome as general associated with retinitis pigmentosa? Can you mention for me, please?
Yes, there's syndrome association like Usher, like Rafsam, like Usher, but apart from the patient, there's any problem to, yes, you need to examine the sense, ear examination, and the patient, there's no any using any earpiece. There's Rafsam, there's patient, there's no ataxia, no symptom to the congestive heart failure. And also there's no any polydactyly. And yes, there's
what?
no any polydactyly.
For what? For what? Polydactyly for what, Doctora?
Yes, hello?
Yes. Polydactyly for what? Which syndrome?
Yes,
Yeah.
polydactyly, Lawrence syndrome, and also ear problem for Usher disease, and also congestive heart failure for Refsum disease, and there is no any sensory ataxia or lower limb weakness for Friedreich ataxia.
Did you examine for cerebellum? Did you check the patient for cerebellum?
Cerebellum for what?
Did you check your patient?
No, just only no.
Okay, so what is the syndrome? It might be associated with cerebellum infection in this patient.
Yes, regarding this patient, Friedreich ataxia.
Anything else?
And Refsum disease.
Okay.
And there's there's other syndrome. I think I forget name.
Okay. Did you check the sensation for this patient?
syndrome. What?
Sensation. Did you check it?
Yes, check the sensation,
Okay.
check the gait, ataxic gait, and dorsal column.
Okay. So what is a syndrome associated with peripheral infection, neuropathy infection?
The syndrome is affected the sensory. Friedreich ataxia and Usher. Friedreich ataxia and Refsum disease and Sinclair syndrome.
Okay. Yes, you are right.
Mhm.
Yeah. Karen-Sayer syndrome. This is the syndrome associated with peripheral neuropathy. Okay. Okay. So, if I ask you regarding to give these patients two advice, which advice? What advice is the most important for this patient?
Regarding advice this patient regarding to the vision.
Yeah. Okay.
Referring to the occupational and vision, and also advice just only for
Yes.
vision.
So,
Mhm.
two advice you need to give this patient two advice.
Yes, and advice to the patient to stop driving.
Okay. Anything else?
No.
Okay, smoking. If your patient is smoking, yes, we need to advise her regarding to stop smoking. Okay.
Okay.
Also, other family screen. Okay. So, what is the investigations we need to do for these patients?
Yes, apart from the basic investigation, I want to do the genetic test. Yes, I want to do the genetic test.
There is a special diagnostic test for retinitis pigmentosa.
Diagnostic test like
Yes.
diagnosis by genetic test, I think. The special
No.
diagnosis by genetic test.
مرام ولا okay. Yes, retinogram.
Mm-hmm. Okay,
Okay.
electro.
Okay. So okay. What is the treatment for this patient? The plan of management.
There is no treatment. Disease is not curable, but we can give him the vitamin A to reduce progressive of the disease.
Okay. Mm-hmm. Okay.
Yes.
Thank you. Finish now.
Okay,
Mhm.
thank you, Dr. Sarah. Any other questions? Can you comment?
You mean I comment now, or do you have a
Yes,
question?
yes. After no. If you have question, ask her. If no more, we can move for the comments.
Yes, I finished. I am finished.
Okay, you can start commenting now, please, about the performance,
I
about the
guess
case.
actually she did well, yeah. Just I think retinitis pigmentosa and syndrome associated is a little bit confusing. So yeah, the important things she examined regarding the hearing aids, the most important for Albert, Riftham, and also the cerebellum is the most important as I mentioned. Yes, and also we need to check the peripheral neuropathy. He already checked for this. Regarding the fundoscopy, just we need to take a permissions from for the patients from the patients regarding I'm going to examine you with this examine your the back of your eyes with this instrument, and I will bring this light might do not harm you, but it might be a little bit discomfort for you. So after that, and also I need to get a close for you, and sometimes I need to yes put my hand or in your shoulder. So we need to examine the right to use the right hands to and to examine the right eye, okay, and the opposite for the other eye with your left hand, okay. So yes, regarding the first pictures, there is the tunnel vision, which is a loss of peripheral side or side of the vision, which called like bitemporal hemorrhage.
Sorry, Dr. Sarah, we cannot hear you. Hello, you can hear Dr. Sarah?
No voice.
Dr. Sarah, I think there is a problem in your connection. We cannot hear you. Okay, I will ask Dr. Rasha now why you said, until Dr. Sarah will join back, why you said this is isolated retinitis pigmentosa. How do you know? What guarantee?
Yes, because there's no ask about any other no examine about any other association syndrome. There's negative.
Okay,
I'm
what
sorry,
about
just I think I have some internet problem, yeah,
No
connection
problem.
problem.
Okay, I will just comment on this part. She said
Yeah,
isolated, and
you
I
can
asked her
comment
why.
now.
Yeah, yeah. No, no, not about the case. Only about this because you lost the connection. Then I start a question. Why she mentioned isolated retinitis pigmentosa while she didn't have full history from the patient. She said she did some examination and she ruled out some of the differential, but about a beta lipoproteinemia, what do you think? Was it there, and how you can rule it out by examination?
Yes, yes, A beta.
There's sensory manifestation.
Yes.
There's also sensory ataxia.
Yeah, what I mean, you have to say, I would like to take full history to roll out.
Yes, cerebellum ataxia also included in the
other,
apical
yeah,
lipoproteinemia.
other syndromes.
Yes.
Anyway, okay, let's continue your comment, Dr. Sarah, please. Can you resume your
Okay.
comment? Okay.
Okay. So the cerebellar ataxia or cerebellum infection is important for rhythm and apical hypoproteinemia and Karen-Sayre syndrome. Okay. Um. Yes. Regarding yes. I think.
I think
Um.
Sire with
Yes.
cardiomyopathy, Dr. Rasha, Dr. Sarah.
Yes. Also included in the card.
لا not cardiomyopathy, heart block.
Peripheral neuropathy and heart block. Yes. Pacemaker now because of Karen-Sayre.
Okay, continue.
Mm-hmm.
So for each syndrome and the specific manifestation, again the Lawrence Mohnbidel with extra dactyly, right? And
Polydactyly
obese.
for Bardet
Yes.
syndrome. Bardet syndrome. Yes. Bardet syndrome.
Okay, and he will be also having intelligence issue
Mm-hmm.
Yes.
and
Mental
Yes.
morbid
retard.
obese, morbid
Mhm.
obese, right?
Morbid obesity. Yes.
Okay,
I think also I think also child, not young.
yes, a child.
Mhm.
Then the second syndrome will be Kearns-Sayre, or let's start from up downward. So the hearing
The hearing
syndromes,
affected. Yes.
Usher and
Hearing, Albert.
Albert
Usher
and
and Albert.
Usher
Albert and Refsum
Mhm.
also.
and Rifsam, yes.
Yes.
Okay, what else? Then the next will be cerebellar syndromes.
Beta lipoproteinemia.
Okay,
Mhm.
Yes. Refsum also and Karen-Sayre.
and Friedreich
Yeah,
attacks.
Frederick attacks. Yeah.
Okay, then
Friedreich attack. Yes.
we'll go for the peripheral neuropathy. Again, we will add Rifsam and beta
And Friedreich
lipoproteinemia
attacks. Yes.
and Friedreich
Frederick
attacks.
attacks.
Yeah, then the diarrhea, you will add it to the beta lipoproteinemia specific.
Yes, during anterior.
Mhm.
The heart block, we mentioned already, Kearns-Sayre.
Mm-hmm. Yes.
Mhm.
And I think, yeah, no more syndromes,
Yes.
isn't?
The most common syndrome associated with retinitis pigmentosa is Usher syndrome.
Yes, Usher.
Albert also, they brought before Albert.
Yes, just the most common. The most common syndrome, Usher syndrome.
Okay, so the Usher will
All
have
the
hearing issue, peripheral neuropathy, and retinitis pigmentosa. Right?
Yes.
Mm.
Okay, any other syndrome? Anyone want to
Yes,
add?
you meaning like
There.
yes, you meaning like this case, you need to examine the pulse. For bradycardia, you need examine the cerebellum, you need examine the hair, and patient
Yeah.
and also if the patient using the hair aid, and also you need to examine the lower limb, and also you need to examine the gait, and you need to auscultation the heart. Yes.
Yes, exactly.
Yes.
Okay.
Yes. Okay.
If not all
Actually,
of
another
these,
syndrome which
okay.
called Warden-Bering syndrome. If you are hearing regarding this syndrome, which include prominent nasal fold and heterochromia of the iris. Yeah.
So I didn't hear
A
about
white.
it. Anyway, yeah,
Yeah.
it's
It
not
is rare.
common. Yeah, it's
Yeah, not
rare.
common.
Okay, let's say we rolled out all of these. So this is the time to say, as Dr. Rasha said, isolated retinitis pigmentosa. And by the way, not all of them are autosomal dominant. Not all of them
Yes.
as X-linked or autosomal recessive. So some of them and some the others are different in the inheritance. Okay, so no specific mode of inheritance. There is different mode of inheritance in each syndrome. Okay, clear?
Yes.
Okay. Any comment or regarding the performance apart from the we mentioned? Any question else?
Yes, what the advice you want to give to the patient?
Yes,
Yes,
driving and smoking.
driving and smoking, yeah.
Okay.
And also you have to tell him it's progressive disease and might he will be blind.
Completely blind, yeah.
Yes, it's important. Okay. Again, for the genetic screening, if he has planned for pregnancy or if she is planning for pregnancy or if he is a male and he's planning for having a baby, he should do also the family no, genetic screening for sperm selection. Okay. Any comment regarding the
Mhm.
retinitis pigmentosa? Anyone want to comment or to add any suggestion?
What is the
Yes,
investigation?
sorry. Yeah, as you mentioned, you'll do
Listen,
every, yeah, but this is the specific. You have to do general investigation to rule out any anemia, to rule out other association, and you can do some specific tests for the syndromes, like a nerve conduction study for peripheral neuropathy. You can do MRI for the cerebral affection. You can do this as an image. You can do also base,
ECG echo, yeah.
ACG and echo, yes, for the
ECG
heart.
and echo, yes.
Exactly. Yeah.
Mm.
And the genetic testing to confirm the diagnosis.
Hearing assessment.
Hearing,
Hearing assessment,
exactly.
yes.
Yes, hearing for Rifsam and other
Hearing assessment.
Usher. Yeah. So it depends and no specific investigation. You can do a lot to reach with to the association, but the case is already
Association complication.
confirmed by the fundoscopy. The fundoscopy is confirming the retinitis. Now you want to diagnose what under which syndrome this patient is diagnosed. So you have to do the other investigation to confirm the syndrome, or to say this is a syndrome.
Electroretinogram also,
Yeah.
diagnostic.
Okay, this for the retinitis pigmentosa as well.
Mm.
But for the syndromes, you have to do the other tests. If you rolled out all of them, you can say this is isolated retinitis pigmentosa. Okay, clear now for all. You will be lucky to have retinitis pigmentosa if you know how to use the fundoscopy.
Lucky?
If
No, I
yeah, this is
didn't
the
think.
problem. Yeah, if you don't know how to do it, you'll be in trouble. At least you can guess it by the fields. So whenever you ask him for the peripheral fields, he will not see all the peripheral fields. The nasal
And night
and
vision also, night vision.
this is history taking.
Yes, from the history.
Yeah, so you can say, I would like to take history about his vision, the timing, is it affected during the night only? The color vision as well is very important. In this scenario, also, he's having color affection. So it's a matter of long clinical. If it comes as long clinical, you might know the case. But if short, you'll be in trouble if you don't know how to use the fundoscopy. Because from the history, you can know the manifestation from the history taking. And the night vision, the color vision, and the family history will confirm the diagnosis. Or you might have the an association, peripheral neuropathy as a questions, or heart affection. But while doing the short, if you don't know how to do the fundoscopy, maybe you will fail the case, or you will fail the station, and you will not know reach the diagnosis. Okay. Any question regarding retinitis pigmentosa? It comes before as long, by the way, not only as short. So BRD in some centers, it's not commonly comes, but it comes. They have the case and they will offer, whenever you offer the fundoscopy, they will tell you, yes, proceed. So be ready and try to train once in the whole practice on the fundoscopy. Only once. Okay, clear for all?
Yes, clear son.
Yes, واضح. جزاك الله أحسن.
Okay. Anyone want to comment or to suggest something regarding the arthritis? By the way, the surrounding here is important. The patient might have a stick, the white stick. If he's progressively blind. Other questions? Anyone want to add any comments? Dr. Rasha and Dr. Sarah, thank you for the presentation today. Sorry, Dr. Emika again. I promise you for a station you will do next week. Just choose what station you want to do, and I will give you the priority, either long or communication, because next week will be only for long and communication. Okay? Message me privately, please. What day can suit for you? Then I will let you do the practice. Okay, Dr. Emika? Anyone want to ask before ending the session? Okay. If no, we'll wish you the happy and nice weekend. See you inshallah in the next week on Saturday. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Awesome.